everyone. Welcome to Maternal Medicine EMQs YouTube live session by mrcoG courses. So today we are going to solve EMQs for the maternal medicine, which is a very, very important topic, and it forms a major part of the paper 2 EMQs, and that's what we are going to do today. It's a very, very important topic. Let's solve, and we are going to take one after another, almost 15 EMQs, which we will be covering today. And then we'll discuss the important points about every EMQ, and we will decipher how we are going to solve and pick up the right answer among the long list of the questions. I am pretty sure most of you are so much confused in the EMQs. Everybody can bring down the options to last 2 or 3, but then finally, which one is the best and what rcoG is looking for is the one which makes you confused. So no worries. Today we are going to learn in a very, very simple way, and keeping our motto of studying in 70% study time, less study time intact. We'll see how we can learn things in not by putting in more hours, but preparing it for the exam in a smarter way. So here we go with the first EMQ. So I would like to have all the answers in the chat box. So please keep writing the answers. And the one who is going to answer the first, I'm going to announce his name as well. So please keep answering and keep the session live and interactive, and see your name in the session as you answer the fastest finger first. So here we go, and here we start. So let's start. So 27-year-old woman with the type 1 diabetes mellitus attends the antenatal clinic at 38 weeks of gestation. So first and foremost, it is very important that whenever you have a question of such situations where there could be multiple scenarios, like in a diabetes, that could be type 1, type 2, or GDM, and everything has a different further prognosis and further monitoring. So be very careful. Once you start, you should ideally pay attention what you are dealing with. So in this question, we are dealing with the type 1 diabetes. Diabetes has been poorly controlled, and the fetal abdominal circumference was on the 50th centile of the femur length on 25th centile at 34 weeks of gestation. So abdominal circumference is 50th centile and femur length is 25th centile. So I think that's pretty good. That's okay. So ultrasound scan now shows the abdominal circumference becomes 95th centile and the femur length on the 20th centile. So what is happening here? So now what has happened? It is increased from 50th centile to the 95th centile. So what is the cause here? Like uncontrolled diabetes, definitely. And what do we call this situation as? This is a macrosomia. Now that means that the GDM, the type 1 diabetes is improperly controlled and the complications has occurred. Like a volume and umbilical arteries, Dopplers are normal. Does this line has any significance in answering this question? No, this is a distractor, because once you look at this, you might be thinking that everything is fine, but it is not. This is a total distractor which rcoG is added to, so that you think that it's okay, but it's actually not okay, because the macrosomia has already set in. So what is the correct answer here? What is the correct option here? Let me have the answers in the live chat. Looking for your answers. That should be yes. Okay, I can see many of your, yeah, Dr. Sunita, good evening. Very good evening, Dr. Swati, Dr. Beena. Yes, Dr. Anupam Singh, Dr. Francis, Dr. Priyam, Dr. Sabita. So good to see you all here, Dr. Poonam. Yes, let's see what are the answers. So the options here are HIABA. Okay, so what is H? A cesarean delivery to be performed as soon as possible. I is planned cesarean delivery by 38 plus 6 weeks gestation. And A and B. A is induction of labor without delay, and B is induction of labor at the earliest opportunity. And the D option, okay, That is the last option, planned cesarean delivery at 39 weeks. Okay, so what I get from all of your answers is everybody knows that it's time to deliver, right? So it's time to deliver, but we have to decide two things, whether we need to deliver now or we should take some time. And second thing is, what should be the mode of delivery? Induction of labor or cesarean section? The birth weight is not given here. So we cannot actually go with that like it is more than 4.5 kg, then we know that it is going to be 100% cesarean. But in this case, still it is above 95th centile. So macrosomia is definitely there. So we will prefer doing the cesarean section in this case because the risk of macrosomia and the shoulder dystocia. So your option will be for the cesarean section. Now, if I look at the options of cesarean sections, it starts from F and go till J. Now, it depends on what type of a cesarean it is. So it is not an emergency cesarean section because patient is not in the labor. So that's okay. So basically, now it is 38 weeks already there. So what is the timing which is guided by the NICE guideline? It is between 37 to 38.6. So why would we wait till 38 plus 6? Already the diabetes is uncontrolled. So already patient is in that window of 37 to 38 plus 6. So why not go for the cesarean section? So the best answer is H. Cesarean delivery to be performed as soon as possible. And let me check who is the fastest finger first. That is the Dr. Sabita. Dr. Sabita. 3 cheers for Dr. Sabita. She got the answer right. But 3 cheers for everyone who tried answering and managed to put the answer in the chat box. Now you will never forget this answer by the time you go to the exam. So this is diabetes 37 to 38 plus 6. The NICE guideline says that offer induction of labor or cesarean section if indicated to women with type 1 or type 2 diabetes, otherwise await spontaneous labor. Now there are two concerns here because the diabetes is uncontrolled here and the macrosomia is happening already. So there are two main concerns. One is because of this, the IUFD, diabetes, uncontrolled diabetes is a very big risk factor for the stillbirth, right? So IUFD can happen anytime. And another thing is shoulder dystocia with the vaginal birth. So therefore, birth should be recommended as soon as possible by cesarean section in the given gestational age. Now you would say that guideline does not mention that we have to do cesarean section. Then why I am choosing the cesarean section here? This is the intensity which rcoG is testing nowadays. This is the same kind of a question which you see nowadays in the exam where the words does not give you the answer, but the concept gives you the answer. The conceptually, yes, this is the time to deliver the patient, but whether we have to choose the vagina or the cesarean, right? So in cases of these patients, because uncontrolled diabetes, see the level of worsening. The patient has worsened. So when the patient is worsening, so macrosomia is certain complications are already there. Patient may have IUFT any time. And if she delivers a macrosemic baby, shoulder dystocia risk is there. So that is why it is basically we are choosing the cesarean section here. Now there is a query here. So any role of antenatal corticosteroids? Yes, we can give corticosteroids. No issue about that because this is not an urgency. We can wait for 48 hours and we can give the corticosteroids and manage accordingly. So that's the correct answer here. So H is the correct option. I think clear to everybody. Any questions about this? And then I move on to the next question. Okay. So a 23-year-old pregnant woman presents to the antenatal clinic after her routine anomaly scan at 19 weeks gestation. The scan shows a structurally normal fetus and the fetus is identified as female. She is concerned that there is a 50% chance of her condition being passed on to the baby and that her pregnancy carries a higher likelihood of precipitate labor and increased risk of perineal injury. Okay. So now what? What are the features here actually for which we are trying to look at? So one feature is that fetus is scan shows the structurally normal fetus. Okay, so there is no congenital anomaly as such, but 50% chance the baby will be having this condition. And what are the problems in the mother? She is having the higher likelihood of precipitate labor and the increased risk of perineal injury. Now, what does these two things specify? Precipitate labor and the increased risk of perineal injury. What does these two things has the importance of? So precipitate labor is like the early pelvic relaxation, and the second thing is the tears, perineal injury. So what does this signify? A problem in the connective tissue disorder. So now, if we talk about the connective tissue disorder, what is the correct answer here? What is the correct answer here? Okay, so if we look at the connective tissue disorders, we have Marfan and we have Ehlers-Danlos syndrome. So which one can be there? If when we come to the organs, skin, connective tissue, it is more of Ehlers-Danlos. Marfan has predominant cardiac things, but when it comes to the uterus, the connective tissue, the perineal muscles, it is the Ehlers-Danlos. Many of you have got it right. Dr. Sabita, Dr. Poonam Kashyap, Dr. Prayam, Dr. Magdalene. Okay, so I cannot go for G or C, right? So because we don't have any option of taking two things, right? So Dr. Meenakshi, Dr. Prabhati Ram, Dr. Divya Selvaraju, Dr. Sunita, Dr. Kirti. So many of you got it right. So, but again, the fastest finger first is Dr. Sabita. Oh my God, we need another winner also. Otherwise, she will have a hat trick. She got two right. So another one goes right and there's a hat trick. Okay, so here the correct answer is Ehlers-Danlos. So let's learn a bit about the Ehlers-Danlos. If you see hypermobile joints, stretchy skins, and easy bruisability in pregnancy. See the hypermobile joints and the stretchy skin. It immediately correlates with the connective tissue. And think of one condition that can turn this normal labor into the high risk one, and that is the Ehlers-Danlos thing. So because the tissues are fragile, everything tears, bleeds, and heals. So during pregnancy, joint pain worsens because there is laxity, mucosal bleeding, epistaxis, gum bleeding, GI symptoms, reflux, constipation, cardiac valve issues, minor but testable. And the labor, precipitate, perineal trauma. Postpartum, you can have PPH and the wound dehiscence. Anesthesia, you will have a reduced efficacy and the airway difficulty. Why the airway difficulty? Because the same connective tissue in the trachea, right? It creates the problem with the airway entry. What is the management? Do we need cesarean section because of the perineal trauma or the precipitate labor? No. We just need genital tissue handling. Vaginal delivery is very much preferred. Early episiotomy if needed because we want to avoid the tears. So low threshold to prevent and treat PPH. Then you have the anesthesia, less effective, need top-ups and difficult airways. Another very important thing is postural orthostatic hypotension. This is very much associated with this, right? So dizziness, syncope, sudden increase in the heart rate on standing by 30 beats per minute is something which you can see in the Ehlers-Danlos syndrome. One of the favorites, right? Ehlers-Danlos, Marfan, they are one of the favorites of the RCOG. So that's it. Okay. So how will you differentiate the two conditions? If the cardiac features are predominant in your question, choose the Marfans. If the organ systems like uterus, connective tissue, these small capillary, these things are significant in your exam, choose the Ehlers-Danlos. So this is how you are going to make the difference in the two conditions. Okay, this is how, if you fix your keywords, we call them as formulas in our course. So if you have these kinds of formulas ready, it becomes very easy. So go ahead, have those formulas and just apply them in the exam questions and get your answers right. So here is the EMQ 3. A healthy 29-year-old woman presents at 30 weeks of gestation with itching in her palms, feet, and abdomen. Her skin appears normal and there are no other symptoms. Blood pressure is 123 by 62 and urine analysis is normal. Full blood count is normal. ALT is 72. Bile acids are 32. And 1 week later, ALT becomes 90 and the bile acids become 45. Now the BP, urine analysis and all other blood tests are normal. Now, what is the next step? What is the most appropriate step in the management of this patient? So here we see that bile acids was 32 and it has become now 45. Okay, so I can see H, I can see K. K is what? Weekly. H is the ursodeoxycholic acid. Okay, F, what is the offer birth at 37 weeks? Okay, C is weekly LFT and bile acids. Okay, Magdalene, I, that is weekly FG and the bile acids for weekly growth scans. Okay, so G is what? Offer birth at 38 to 39 weeks. Okay, so currently the patient is at the 30 and then 31 weeks, right? So do we need to talk about something else or we just need to go ahead with the directly go ahead with the delivery? We can talk about something before that, right? We can talk about something before that. What is the monitoring? The question is more about the monitoring because she is 31 weeks, right? So what is the monitoring? Now, as per the various options here, you guys are mentioning about the weekly LFT and the bile acids. Okay. So basically, I understand what is the confusion. This weekly and bi-weekly testing was the part of the previous guideline, which used to be there. But now the guideline says that it has to be individualized. Okay. Initially, you do one testing, then you repeat a testing after 1 week, and after that, further monitoring is individualized. This is what the current guideline says. So when it is, we have already tested twice. We have done once, and then after 1 week, we did it again. So what to do now? Now it is basically because it is individualized. So it is more like when you are close to the delivery date, like it is, you know that at this point of time, you will be delivering at 38 to 39 weeks. So prior to that, like from 35 or 36 weeks, you can start the weekly testing. So now it is 31, so you can start testing around 35 weeks. So what is the correct answer here is LFTs and bile acids at 34 weeks. Now we don't have to do every week, right? We can just wait because this is moderate level. We are waiting till we will do the early delivery even at 37 weeks at 100, okay? Not before that. So we need not keep doing it weekly. We can now do it at 34 weeks. So D is the correct answer here. I'm afraid nobody has done the correct answer. So if the woman has mild ICP with the peak bile acids 19 to 39, they could have weekly testing as they approach 38 weeks gestation in order to inform timing of birth. If the woman has moderate ICP with the peak bile acid 40 to 99, especially if they are approaching 35 weeks gestation, weekly testing should be considered as timing of birth may be influenced if the levels rise to 100 because your delivery timing is going to start from 37 onwards. It is not prior to that, right? So therefore, we can wait till that time. Okay, so this is how the correct answer is. Now coming to the next EMQ. I'm pretty sure this is a good option for, this is a good opportunity for any one of you to have the fastest finger first. And I know many people are there here who just want to be fastest finger, but this is the good question where you can actually pick up that opportunity. So let's see who does this. This is an easy question, very direct. I'm pretty sure everybody of you know this question. So 24-year-old woman has a history of headaches before she became pregnant and was awaiting the investigation by the neurologist when she became pregnant. She presents at the 12 weeks of gestation with generalized non-throbbing headache, which is worse when she coughs or strains. She also complains of periods of double vision. There is papilledema on clinical examination, but no other neurological signs. What is the most appropriate diagnosis with this patient, right? So, what is the most appropriate diagnosis for this patient? So, what is this? Okay, I was expecting a new winner. Yes. Yes, yes, yes. What is this? See, papilledema. What does this shows? Papilledema, non-throbbing headache, early pregnancy, 12 weeks, right? So what it is? What it is? Yes, 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 yes. I can see two, three correct answers here. Why? Everybody is confusing with the CVT. CVT occurs later in the pregnancy, right? Later in the pregnancy. So this is D, yes. See, whenever early pregnancy scenario is there, think about benign intracranial hypertension. And why it goes in favor of intracranial hypertension? Because one feature, papilledema is there. Secondly, it is getting worse when she coughs or strains, right? So when she coughs or strains, it gets worse. And secondly, it is papilledema. So both of these features signify the hydrocephalus, right? Sorry, this increase intracranial pressures. And whenever the increase intracranial pressures in early pregnancy, benign intracranial hypertension is the cause. Now, why it is not H? Because I can see H answers also here. So to make it, I think the confusing ones here are the double vision and the papilledema, which is making you confused for the CVT. But CVT will have some risk factors, and usually it is there in the end of the pregnancy or the postpartum period. And it is like there will be some neurological signs, right? It is not that it does not have some kind of a neurological signs. There will be some neurological signs because some part of the brain is definitely affected when the trauma is there. So you will have the neurological signs in that case. So the correct answer here is the benign intracranial hypertension. Okay, now coming to this question. The similar kind of a question appeared this time in the January 2026 paper as well, which was not of 7 weeks. It was the late presentation. But here we are taking a question about the 7 weeks just to make you show that how the simple change in the question can actually change the whole concept. So a 23-year-old woman attends the antenatal clinic at 7 weeks of gestation in her first pregnancy. She has a history of epilepsy treated with lamotrigine, 100 milligram twice a day. She has a seizure about once every 6 months and her seizures remain well controlled. What is the most appropriate advice at the moment? What is the most appropriate advice at the moment? Yes. Who is going to answer this? Again, an easy question. Again, an easy question. So basically, patient is in 7 weeks of gestation with a history of epilepsy and she is on lamotrigine 100 milligram twice a day. So what to do now? Okay, blood level, okay. So no, yes. One option here is G, another option here is C. Then another option is C. Okay, G and C, G and C. Yes. Oh, I'm so happy we have a different winner here. So, yes, B is the correct answer here. Yes, Dr. Kalpana Mishra. That's it. Previously, I should first do an applause for the Dr. Sabita because she got the hat trick in the previous three questions, right? So here is a round of applause for Dr. Sabita. And now in this question, we have a new winner. I'm so happy to announce that that is Dr. Kalpana Mishra. So B is correct answer here. Why we are not talking about the lamotrigine here? Because patient is at 7 weeks of pregnancy. Okay. So now in 7 weeks of pregnancy, we have to give the folic acid 5 milligram. Now why we are not choosing the C option? Because it says blood levels for lamotrigine levels and the folic acid 5 milligram daily. Okay. This is what the C option says. So why we are not choosing the C option? Because there is no monitoring of blood levels of lamotrigine, right? We just have to adjust the dose, but blood levels are not routinely monitored. So therefore, now this is a very, very important to understand that, because NHS will not do extra tests, and they will do all the essential ones, but they will not do extra things, right? So blood level monitoring is not a part of the lamotrigine management. And why would we change the lamotrigine to levetiracetam? Lamotrigine is a safe drug. If the patient is stable on that, we don't have to change it. Okay. So that is not required. Blood for lamotrigine levels in every trimester. Some of you have chosen J, but again, that is the same thing. Blood level monitoring is not done, right? So here B is the correct answer. So ensure taking the folic acid 5 milligram daily. That is the correct answer here. Okay. So in the question which was there, which we previously discussed in one of the sessions, there was 12 weeks pregnancy. At that time, we said decrease the dose of increase the dose of lamotrigine. We did not say we will monitor the levels of the lamotrigine. We just say that we will increase the dose of the lamotrigine in that 12 weeks patient. Okay, because at 12 weeks, the role of folic acid is almost over. But here the patient is at 7 weeks. That's how, like a small twist will twist the answer. Okay, now coming to early pregnancy, so folic acid. Yes, that's perfect. Perfect concept. 25-year-old woman has an emergency cesarean section under general anesthesia at 32 weeks of gestation following an eclamptic seizure. Blood pressure remains difficult to control postpartum and she complains of headache with nausea and vomiting. You have been asked to review her urgently because she complains of visual loss affecting both eyes. What is the most appropriate diagnosis for this patient? Now, what is happening here? She is had an emergency cesarean section which was done under general anesthesia, and at 32 weeks of gestation following an eclamptic seizure. Blood pressure remains difficult to control postpartum, and she complains of headache with nausea and vomiting. You have been asked to review her urgently because she complains of visual loss affecting both eyes. Now, very carefully, we have to answer what it is. Oh my God, so much correct answers. Very good, perfect, very nice. So, who has got the correct answer? Yes, another new winner now. Very good. More and more people should come forward and be the fastest finger first winner. So here it is, Dr. Priyam. Dr. Priyam, F is the correct answer here. This is posterior reversible encephalopathy. Now, okay, so what are the other confusions? Let me look at that. In intraventricular bleed, no. Intraventricular bleed, patient will have sudden unconsciousness, right? Very low score. And then there is J. J option is what? Acute cerebrovascular event. No. So this is basically C. What points towards the press, right? So because it is, there is a preeclampsia associated with it, right? And then blood pressure is difficult to control and she complains of nausea and vomiting. So that all goes in favor of press. So press is associated with preeclampsia. Presents with a headache, vomiting, visual disturbances, seizures, and altered mental state. And there is MRI shows edema in the posterior circulation of brain. Cerebral autoregulatory response is impaired, leading to breakdown of the normal blood-brain barrier and culminating in the vasogenic brain edema. Follow treatment algorithm for severe preeclampsia with blood pressure control. Prevent the seizures and prompt delivery of the baby is required. Epilepsy, we are gonna continue throughout pregnancy in folic acid. Yes, we continue, but most important is up to the 12 weeks. That is the more important. Rest depends on the drugs. Okay. So that depends on that. Okay. So now coming to the next question here. A healthy 38-year-old woman presents to the maternity assessment unit at 20 weeks of gestation because of recurrent episodes of severe headache. Now, what is happening? Recurrent episodes of severe headache are there. She experiences up to 5 episodes on a bad day with severe pain on her right forehead, with tears running down her right cheek. She has no neurological symptoms and the pain is not associated with nausea or vomiting. Now, what is there? Yes, we already have the answer here. So, yes. Any more answers? Any more? Yes, looking for the new winner. Yes. And we have got the new winner, Dr. Swati Jain. She has done the fastest finger first. So that is cluster type headache. Cluster type headache. So fastest finger first, cluster type headache. That's the correct answer here. So what are the keywords which go in favor of the cluster type headache? Tears running down the right cheek. Severe headache in the right forehead. So cluster headache, this is basically the primary neurovascular headache disorder. Attacks of severe or very severe strictly unilateral pain, orbital, suborbital or temporal pain that lasts 15 to 180 minutes and occur from once every other day to 8 times a day. Associated with one or more of the following, all ipsilateral, one side, right? That is present here. Conjunctival injection, lacrimation, nasal congestion, rhinorrhea, forehead, and spatial sweating, meiosis, ptosis, and eyelid edema. So, okay. So that's it. So cluster headache is the correct answer. Okay. Now the next question. And I'm looking for another new winner now, right? So let's see who is going to get this. 34-year-old man telephones the maternity assessment unit because his wife is complaining of sudden onset severe headache. The woman had a spontaneous vaginal birth 3 days ago following induction of labor for post-dates pregnancy and needed spinal anesthesia for manual removal of placenta. The woman was changing her baby when she started screaming in pain and holding her head. There is no history of migraine. Now what? What is this? She is having a sudden onset headache. Sudden onset severe headache following induction of labor for post-dates pregnancy. Okay. A is cluster, M is postural headache, and K is the subarachnoid bleeding. Yes, K is the correct answer. And the fastest finger first is Dr. Divya Selvaraju. And she has got the answer right. So this is subarachnoid bleeding, the sudden onset severe headache. You remember the keyword thunderclap. Thunderclap, right? So that is there. A woman was changing and suddenly she screamed and holding her head with the pain. So that is the keyword for the subarachnoid bleeding. Okay. Okay, so those who are answering the post-dural puncture headache, let me point out that woman had a spontaneous vaginal birth, right? So we are not expecting the post-dural puncture headache in this patient. So M is not the correct answer. And it is not CVT because CVT headache is gradual in onset. This is sudden severe. So it is subarachnoid hemorrhage, right? Sudden subarachnoid. S for S. So remember it like that. Okay, coming to the next question here. 26-year-old woman attends the antenatal clinic at 10 weeks gestation. She is known to be a carrier of Haemophilia B with factor 9 levels of zero 0.4 at booking. Treatment options include 26-year-old woman attends the antenatal clinic at 10 weeks gestation. She is known to be a carrier of Haemophilia B with factor 9 levels of 0.4. The treatment options include. Let's see who is answering. Yes. Looking for the answers. And this time a new fastest finger first winner. Yes. We need a new winner now. Okay, DDAVP. Okay. So in factor 9 levels, do you think DDAVP helps? Which levels increase with the desmopressin? Which levels increase with the desmopressin? Is the factor 9 levels increase? It is factor 8 levels which increase with the desmopressin. So for factor 9, we need the factor 9. But if you see, we do not have factor 9 in the options here. So what is the next best option? That's why I've given you this question, right? Many of the times in exam also you will find the exact answer is missing. That is not there. So that is how you have to fix first best, second best. If this is not an option, this is the third best. So what is the best option here? Yes, I can see the correct answer here, but I'm looking for the more answers. Who else is going to have the answer right? Yes, it is F. F is the correct answer, tranexamic acid. Two people have answered it right, Dr. Kalpana Mishra and Dr. Prabhati Ram. So two people have answered it right, and Dr. Kalpana Mishra is the fastest finger first. For the second time, she had done one prior question as well. Very good, very good. And very good, Dr. Prabhati, as well, because you also got it right. This was a tricky question, right? Simple question that factor 9 levels are below zero point 0.5. So we know that we need to supplement that. But here the RCU just asked you two things, right? One thing is if at what level we should supplement. So here it is 0.4. So definitely we need to supplement. Now what to supplement? What to supplement? We need the factor 9 to supplement, but factor 9 they haven't given in the options. So they have given you the tranexamic acid, and that is why the tranexamic acid is the correct answer here. Okay, now coming to the 10th question. 23-year-old woman and her 24-year-old partner attend for the preconception counseling. The woman has beta thalassemia and her partner has alpha thalassemia. They wish to know the risk of their baby having thalassemia. So the woman and the partner, one person has the beta thalassemia and another has the alpha thalassemia. What to do in this case? What is the option here? They wish to know the risk of their baby having thalassemia. So now what to do here? In this case, what is the risk? Is it 0%? It is 100%? Is it just simply reassured nothing is going to happen? We should refer to the FMU or we should refer to the hematology clinic. What we need to do in this case? Very good, very good. I got the right answers here. Dr. Suvita, Dr. Suvita, that is refer for genetic counseling. That's the fastest finger first. Dr. Magdalene has also answered it right. K. K is the correct answer here. So refer to genetic counseling. These are the conditions where we cannot predict, right? Like what is the chance for the baby to have the disease. So therefore refer to the genetic counseling. Genetic counselor will guide us further. Okay. So two more questions, two more chances to have the fastest finger. First winner. So let's go ahead, be active, and I want a new winner this time. Okay. This is also a very important question, multiple times asked in the exam. 27-year-old Primi Gravita is admitted for induction of labor at 37 weeks gestation. She has a known history of epilepsy managed with phenytoin, but reports experiencing 2 to 3 seizures daily in recent weeks. Her antenatal course has otherwise been uncomplicated with normal blood pressure and no proteinuria. Shortly after initiation of an oxytocin infusion, an emergency alarm is activated. On arrival, she is found in the left lateral position with generalized tonic-clonic movements and unresponsive to verbal stimuli. Now, what needs to be done for this patient? What is the appropriate treatment here? Okay, so patient has a known history of epilepsy, managed with the phenytoin. And now blood pressure is normal, no proteinuria, and oxytocin infusion is being given to her. And on arrival, now the fit is there. So what we need to do in this case? what we need to do in this case? G, B, D. G is what? Acha, lorazepam IV if seizure continues for more than 5 minutes. B is rectal diazepam. D is lorazepam IV. H is the phenytoin IV. Okay, so now this patient, what is the drug of choice? Why we are straight away jumping onto phenytoin? What is the first drug we give in the status epilepticus? We give for lorazepam in emergency seizures. We give lorazepam IV. Benzodiazepines is the drug of choice. So lorazepam IV. Now for the lorazepam IV, we have two options, D and G. So do you think we will wait for first 5 minutes and then give the lorazepam, or we'll immediately give the lorazepam? We'll immediately give the lorazepam. Why would we wait? She is in labor, seizures in the labor. So we need to give the lorazepam immediately. Seizure in labor, lie her on the left, give lorazepam quick. If she still dances, call the diazepam, midazolam or phenytoin to fix. Okay? So remember this good quote, right? The musical quote, lie her left, give lorazepam quick. If she still dances, call diazepam, midazolam or phenytoin to fix. That's what we are going to do. So lorazepam is the first choice here. Now what is the drug dosage? Because they ask you sometimes about the dosages as well. So lorazepam IV 0.1 milligram per kg, usually a 4 milligram bolus with a further dose after 10 to 20 minutes. Diazepam 5 to 10 milligram administered slowly intravenously is an alternative. If no IV access, diazepam 10 to 20 milligram rectally repeated once 15 minutes later. If there is a continued risk of status epilepticus, or midazolam 10 milligram as the buccal preparation are suitable. So that's the correct answer here. So who answered it as B? Again, okay, Dr. Kalpana. Dr. Kalpana Mishra again for the third time. She is the fastest winner first. Okay, now this is the last chance to be the fastest winner, right? So let's see who answers this. Everybody on the toes, right? So we are going to take this last question now. So 37-year-old multiparous woman presents for the induction of labor at 37 weeks gestation. She has a known history of epilepsy managed with the phenytoin and reports experiencing 2 to 3 seizures per day in recent weeks. Her antenatal course has otherwise been uneventful with normal blood pressure and no proteinuria. While you are discussing the induction process and obtaining consent, she suddenly develops a generalized tonic-clonic seizure and becomes unresponsive. She is placed in the left lateral position and initial resuscitative measures are initiated. Now it's time to do the continuous electronic fetal monitoring should be commenced. What to do now, right? Continuous electronic fetal monitoring should be commenced. So what needs to be done here? Yes. Okay. So yes, last chance to be the fastest winner first. So here we go. Here we go. Yes. Dr. Meenakshi Mishra, G option. That's the correct. So yes. 3 cheers and the round of applause for Dr. Meenakshi. Yes, G is the correct answer. Many of you have actually named it correct. Dr. Radhika, Dr. Divya Selvaraju, Dr. Magdalene, Dr. Priyam, Dr. Sabita, Dr. Mohini Jha. Everybody has answered it right. So yes, see, the question is more about when to do electronic fetal monitoring in the patient who has got the seizure. So the correct answer is the mother has been stabilized. When the mother is stabilized, then we go for then we go for the CTG monitoring. So we will wait for the mother to stabilize to go ahead with this. Okay. So that's the correct answer here. So we did pretty good. 12 questions in last 1 hour. And I think every question was a recall question and a multiple times asked question in exam. And now you can see that how intensively, it is nothing new. It is nothing new. We have been reading these concepts, but we have to go one level deeper and understand those concepts. And this can come if we do not go wider, rather increase the depth of our study. So it's highly suggested that don't try to read each and every word, but focus on the things which repeatedly comes in exam. And that is what we do in our course as well. And if you want to have that kind of a focus study, you are welcome to be with the MRCOG courses. And many of you are already with us, right? I can see many of you in the viewers as well. And I'm proud to say that all of the fastest finger first were actually our students. So that's it. That's the beauty of MRCOG courses. Yeah, thank you. Thank you so much. So, CTG, after the mother is stabilized, if the fetal heart rate does not begin to recover within 5 minutes, or if the seizures are recurrent, expedite the delivery. This may require the cesarean section. The neonatal team should be informed as there is a risk of neonatal withdrawal syndrome with the maternal use of benzodiazepines and AEDs. Yes. Thank you, Dr. Radhika. Thank you, Dr. Magdalene. Yes. Hope you all enjoyed the session, and those who are still not with us, they are missing out the smart, easy pattern of study. Then you can just take the screenshot and share the screen and try to be with us as soon as possible so that you can be prepared in the easy way as well. And in exam, you know the exact correct answers which you want to take. And if you have any doubts, then you can schedule your free meeting with me to discuss about your study plan, and I will be happy to help you out. Thanks a lot. Definitely need to work harder and smarter under your guidance. Thank you, thank you, thank you everyone for joining. Thank you, Dr. Sabita, Dr. Kirti, Dr. Divya, Dr. Swati, yes, Dr. Kalpana, Dr. Meenakshi, Dr. Prabhati. Thank you for joining in, and I hope you enjoyed the session. So let's do MRCOG together in 70% less time together. Okay, bye-bye. Take care. And we'll meet again. Today we are